content. This is not my first time with BestNotes, and I appreciate all the support and the fact that it gets put on YouTube and able to be used by anybody anytime. So we are going to talk about the changes in the criteria. I don't think there's anybody on the program that hasn't heard of them, but there's been several additions. I got involved right in 1991. We did national conferences to roll out the criteria, and I was involved with the second and third of those in 92 and 93. Was on the work group for the second edition in 96, was the managing editor for the 2013 edition, and I was a reviewer for the fourth edition. So I'm quite familiar, and I've done a lot of trainings on this, and I'm happy to be with you today to share what's different. ASAM has not endorsed this training, but they gave me permission to use their own slides. They now have the capacity to have a training process that they do. They have their own speakers, and I've used some of their slides in my presentation for all of you guys today. So ASAM says that the criteria is the most widely used and comprehensive set of standards for level of care recommendations, including continued service criteria and care transitions for people with addiction and co-occurring disorders. It really is the most widely used. That's true. This thing is written up so it can promote individualized treatment planning, guide clinicians and care managers in making objective decisions about whether to admit and to what level of care, and then decisions about continuing care, and then transitions through the continuum. There's a consistent method of assessment of patients. There is a way to do individualized treatment plans based on some of the things you collect in the criteria. And what people didn't think of at first, but we learned this, I mean, what it does is it describes the services that should be available at each level of care. So I think it's the best description of the care continuum of anything, because it tells you what general outpatient, intensive outpatient, various levels of residential care, what should be, what's in the box, what's in the treatment process. So that's a side benefit. So in the summary of changes at the beginning of the current edition, it says the goal is to drive improvements in outcomes. We want to have less undertreatment, less overtreatment, because research shows that overmatching as well as undermatching results in less optimum outcomes. We want everything to be just like Goldilocks, just right. So the standards have been updated throughout the book, and the basic paradigm remains intensity of service is a function of severity of illness. The problem with addiction care around the country is a lot of it's not evidence-based, and the care that's offered patients is what the agency has. Somebody shows up at some place and they get the care that's offered there, even if that's not the best match. You should base the intensity of service on nothing else but an assessment of how sick the person is, what their resources are. So the first thing to do is to determine the severity of illness before you do anything else. And so, again, national standards for continued care and transfer, and it's a framework. It is a framework. And so we'll talk about the framework and how it's a little bit different this time than in the past. It still describes the services offered. So the modalities, who the staff might be, what level of profession should be on the team at that level of care, and how frequently the services are offered. That's actually in each of the levels of care descriptions. So that was in the book in 1991. It still is, though, again, some of the terminology has been changed. Service and staff offered frequency, that's the thing I just said. So that's not changed. Now, again, this is the content of treatment, the setting, the staff, the support systems, the services, the documentation requirements. Is described for each level of care. So again, IS should be a function of severity of illness. So the first thing you do is determine the severity of illness, and then you recommend a level of care. The severity of illness, according to the ASAM criteria, is described by 6 assessment dimensions. They're a little bit different in this edition, and the levels of care have been tweaked a little bit in this edition. Okie dokie. Key concepts. Assessment is not a one and done deal. You continuously reassess. You don't just apply the criteria admission, you apply them periodically to assure the proper placement. So you use them again and again, and that means you reassess the patient again and again to make sure they're in the right level of care. This diagram was developed early on by David Mealy, who was the primary author of the first several editions. He's now retired from the process, and Tori Waller's the editor-in-chief now. But again, you assess the patient, look at the biopsychosocial aspects of their situation. You summarize their problems and priorities, and then you offer care, and then you measure their progress by looking at their severity of illness at T2. T1 is before you do something, and T2 is after you did something. And then you're back to assessment, and it's just a continuous cycle of reassessment. And it's a nice concept, still applies. So what are the major changes? The different levels of care have been numbered a bit differently, but there's a consistency to the numbering, which we'll describe. It integrates co-occurring capability across the continuum. When the criteria first came out, it was for substance use disorders. I think it was the second edition that said for substance-related disorders, because there obviously a lot of people with addiction have mental health issues as well. And there was an attempt to describe in previous editions what was called co-occurring capable and co-occurring enhanced. The authors of this edition say, if you're in the business of doing addiction care, you should have co-occurring capability no matter who you are and where you are. You need to have some capabilities for assessment, at least. I think it was let's see, 2R, maybe it was addition. It was 2R, I think, that developed levels of care for withdrawal management, commonly nicknamed detox, but it's not detox, it's managing withdrawal. And so there were WM 1, 2, 3, 4 levels of care, and those have gone away because withdrawal has been integrated into each level of care. Cognitive impairments have been integrated into each level of care. Harm reduction concepts have incorporated into each level of care. And then the assessment dimensions have been slightly reordered, and then a couple of levels in the non-ambulatory care, what used to be called level 3.3 or level 3.2 WM, they've just been taken out. And level 3, instead of having 3.1, 3.2, 3.3, 3.5, and 3.7, I'm sorry, 3.1, 3.3, 3.5 is now there's just distilled down to 3, not 4. And there's the new level of care is for recovery residences. So sober living facilities have been built into this edition. All right, so now we're really going to get into how the sausage was made. John, my paging did not show up on this slide. I can't read it. What slide number are we at? Do you know?
I'll verify. Give me a minute.
So what are the big changes? Let's talk about the assessment dimensions. You remember what they used to be called, the 6 dimensions. Now there's some subdimensions that are included, and there was a big change. So what you're familiar with is the 6 assessment dimensions in the left-hand column. 1, 2, and 3 have been renamed a tiny amount. Readiness to change is considered to be something to be assessed across the whole continuum, and it's not put into its own assessment dimension. So 5 moved up to 4 with the renaming, 6 moved up to 5. And then the new 6 includes readiness to change and other social determinants of health. So the new dimension 6 are patient preferences, need for motivational enhancement, barriers to care, social determinants, family, social, environmental, neighborhood characteristics, all sorts of stuff. It just gives you a chance to, in dimension 6, say, yeah, all the 5 dimensions, that's all fine and good, but let's talk about this person and what are the extra considerations related to this individual that should determine what we're going to do with this individual. So the overall assessment process is now described as what you need to assess to make an admission and initial placement decision, and then what do you need to assess to actually develop a holistic biopsychosocial treatment plan. So the problem is that the world faces state program certification requirements, Joint Commission or CARF national accreditation requirements, and then there's the ASAM criteria. And there's an acknowledgement that you can't do everything on day one. You have to be kind of sane about this. And so it talks about what salient things do you need to assess to make your decision about initiating specialty care. This is all about specialty addiction treatment. This is what primary care physicians or primary mental health people do to address patients' substance use or addiction. This is for the specialty treatment world. And so what are the bare bones things you need to make your initial patient placement decision? So you got to get into the book to really understand these, but we'll highlight this a bit. So addiction medication needs are now put into dimension 1. Sleep problems are added into dimension 2, but you don't need the sleep problems for making the admission decision. That's a subdimension. It's at a different color on your current slide. And so the subdimensions in black, you don't really have to assess all of that right up front to make the initial placement decision, but to do a treatment plan, you probably should do those things. So the psychiatric and cognitive conditions includes the active psychiatric concerns, the chronic psychiatric conditions that are not states, but they're traits, or it's a very chronic feature of this patient's mental health functioning. Doing a more detailed cognitive assessment, assessing treatment needs related to their history of trauma exposure, their previous response to mental health services are things that go into your treatment plan, but are not essential for the admission decision, the initial placement decision. Likelihood of substance use or substance-related behaviors is all in dimension 4. That used to be called relapse potential, I believe. And then recovery environment used to be called dimension 6. It's now up to number 5. And you look at their level of safety, the level of support, or the lack of support, how they function in their current environment. And then the patient-centered considerations go into the treatment planning, but not into the initial placement decision. So the need for motivational enhancement, patient preferences, cultural issues go into dimension 6. So you might want to look at page 17 of the current edition, or do print out a screenshot or something. This is your little outline. Okay, so what are the new names? Readiness to change is now integrated across all the dimensions. Dimension 1 is renamed. Dimension 2 was renamed a bit. And dimension 3 is acute psychiatric symptoms, cognitive functioning, trauma-related needs. Some of these things, again, were in black on the previous slide. So these are the big changes. That's what we're talking about. We integrate readiness for change throughout. We don't have a stand. So the old 5 became 4, the old 6 became 5, and 6 has a bunch of stuff thrown into the pot, into the gumbo. So, again, I mentioned that the assessment for treatment planning and the assessment for initial intake are differentiated. It's the intake assessment that determines your level of care placement. It's the treatment planning assessment that determines what you're actually going to do to individualize the professional services offered to this individual, the treatment plan. Okay, so all sorts of little cartoons that may help you learn. Patient enters, they're given an ASAM assessment. Their criteria are applied. In the electronic version, these are called decision rules. The level of care is recommended. This suggests that Dimension 6 does play a role in initial placement. We're not here to really critique all the authors. There's a lot of things that I would have done differently if it had been my project. I think Dimension 6 factors are not just for treatment planning. I think they are relevant. Again, what's the patient willing to accept? I mean, that's a big deal about the initial placement decision. But at any rate, they enter the continuum and they move up and down service intensities based on their response to treatment and any other changes they may face. Okay. There's nothing new on this slide that we haven't said. The decision rules are actually the criteria. And then as the patient enters the continuum, they're reassessed to determine if they stay at this level, do they move up or move down? Okay. This is a cartoon version of applying the treatment plan assessment. And then again, the gears get rolling and the patient's actually treated, and then you assess response. So your subsequent decisions, as always, should be what you've always done in clinical care before there was an ASAM criteria. You assess how the patient responded to the initial interventions that you offered them. Did they do what you outlined for them to do? Are they making some changes in the way they think, act, or feel? Obviously, have they changed their substance use behaviors? Are their cravings going up or down? Kind of where is it? So, that was a call I expected, and now we've disposed of it. So always you want to see how they responded and what their current status is. And, you can make it fancier if you want to, but it's good, just good clinical care. You always document how they responded to your initial interventions to decide what your next ones are. And again, you see that in cancer care. How did they do with the chemo? Do we move to radiation or not? So you document their response to initial interventions, and then you make your second version of your treatment plan, and it's a continual process. Okay. Again, the needs in each dimension and subdimension, the strengths, the care coordination needs, what they need for recovery support, what they need for harm reduction, and it suggests that these all become a part of the treatment plan. It doesn't have to be just one person on the team doing it. Assessing these various areas can be done by different people as the patient kind of moves through the treatment process. Again, does new information indicate a need for different strategies? And your care transitions can be up or down the continuum. You adjust your goals and objectives based on the patient's response to care. I didn't even have to read this slide. I just said it already because it's obvious, because everyone on the phone, I believe, is a clinician or has a clinical background. And this is what you do as a clinician, is that you document what happened, and then you adjust the goals and objectives based on the patient's needs. Okie dokie. So the things that are integrated throughout the continuum are withdrawal management, co-occurring capability, cognitive impairments, and harm reduction. And I pulled some phrases right out of the book to make these points about how these are everywhere and not in some sort of standalone assessment process. Okay. So all patients should be co-occurring capable at minimum. The ability to manage mild to moderate acuity, and at least one member of the team is duly certified and has some mental health capabilities. You try to integrate the plans for the mental health problem and the SUD or the SRD. The need to coordinate with external mental health providers, you put that into your treatment plan as well. And so nobody gets a pass. Everybody, you should have some expertise somewhere that can screen, and you can do this by establishing protocols or set assessment instruments that everybody is presented with, has to complete. Obviously, nobody in addiction care should go through the process without being asked if they're suicidal. You just don't do that. You don't have to have any special anything. I mean, if you hang up a shingle and you open the door and you accept people's payment or insurance monies, you should know about their self-harm or harm to others potential. It's so basic, and nobody should say that's outside of my scope. Okay, the levels of care. Now we're going to get into some real changes. Basically, they call the 0.1s, the 0.5s, and the 0.7s tell you what it is. Medically managed care is like the care that's offered in hospitals where physicians or people, licensed independent practitioners who have privileges for admission decisions. Some states that's a psychologist. Obviously, podiatrists and dentists can admit to certain areas of a general hospital. So in medically managed care, a physician or other healthcare provider manages the care. They decide about admission, they decide about discharge, and they decide about what happens every day. They write orders. That's medically managed care. Clinically managed care is managed by a non-physician. It's managed by a clinician who doesn't have to be a physician assistant, nurse practitioner, certified nurse midwife, physician, maybe psychologist, depending on the licensure or regulations in that state. So clinically managed care is the term medically monitored doesn't seem to be as prominent in this edition, but there should be a physician or a advanced practice practitioner involved, and that's described for each level of care. 0.1 is low intensity, 0.5 is high intensity for the stuff that's not medically managed, and 0.7 is medically managed. So they've tried to apply some consistency to the sublevels. So there's a 2.1, 2.5, and 2.7, a 3.1, a 3.5, a 3.7. 4 is just 4. There's no non-medically managed care within medically managed care. So you don't have subdivisions. It's just very intensive, like hospital-based care. And there's not much of that in the addiction world. Doesn't need to be. The old level 0.5 has been taken out. In the old editions, 0.5 was for us brief interventions where substance use was a problem, but addiction had not been diagnosed. That's the way Dr. Mealy and the rest of the team describe level 0.5. That's been taken out. Now this book is everybody has to have a diagnosis, and everybody is getting some level of treatment. And it's not just a brief intervention. Again, this is not what primary care people do. This is what the specialty delivery system does. So as the whole issue of SBIRT grew through the 90s and into the early 21st century, previous editions of the ASAM criteria wanted to pay some homage to that and recognize that brief interventions are clinically effective. But again, they generally weren't done by addiction specialty trained and certified clinicians. They were done in the primary care arena or by health educators. So that's just sort of been taken out. And level 1 has a new level 1.0, which isn't 1.1, It's level 1.0. Now, I mean, I think that a case could be made for different numbering system having been applied to level 1. This is one they came up with, and we'll describe how you actually apply it. And then recovery residences is something somebody can have even if they're in various level 1 and level 2 services. They can be living in a recovery residence. And so we're not going to do a deep dive on that, but ASAM collaborated with NARR, the National Association for Recovery Residences, and they have new nomenclature for their level system so that it could fit with the numerical system of ASAM. OTPs are not a standalone in this book, but certainly any 0.7 could include the use of an OTP. And if the bill before Congress passes, addiction specialists could be able to prescribe methadone outside of an OTP. So we'll see what happens with that legislation. But the group that worked on this edition decided that it wasn't really necessary to demarcate something unique about OTPs. So if you look at these 4 types of services: psychoeducation, psychotherapy, medication management, and a variety of support services, recovery supports. This does pay homage to psychoeducation more intensely. I generally say that addiction is addressed clinically by 3 things: professional counseling, medication management, pharmacotherapy, and recovery support, which can be through recovery support specialists or peer activities through 12-step groups, Smart Recovery, Celebrate Recovery, et cetera. And the recovery support is equally important as professional therapy and medication. This puts a 4th one in of education. And these little colored slides come from some of the ASAM education materials. There's a lot of tools that ASAM has that they sell people that are very helpful. But they've said, patients need a different mix. What do they need for psychotherapy? What do they need for milieu? What do they need for medical services? And then they have this model here of saying that in level 1, it's going to be largely whatever that. It's not really salmon colored. So I'm just going to go back a second. So that's psychoeducation. So they're saying that a 0.1 has a lot of psychoeducation and then a fair amount of therapy and not a whole lot of medical care. And they're saying that a 0.5 is more intensive clinically managed care. And it's largely psychotherapy driven, still with psychoeducation, and maybe a bit more of a medical contribution. But the 0.7s are largely medical, but you don't stop the rest. So, I mean, I don't know if these slides really do much for you. It's just trying to convey another way of conveying how 0.1s, 0.5s, and 0.7s vary. And then the recovery residence is all about the environment the person is in. Education happens, they may be on medication, but the recovery residence is not a place for active treatment. There's not active psychotherapy happening. So it's just, again, it's just a way of describing these. This is the one that you want to keep. This is the descriptor. 1.0 is long-term remission monitoring, which we're going to talk about some today. The 0.5s line up, the 0.7s line up. And we've been trying to give you a preview of that, but this is a good way of looking at it. Recovery residences are on their own, and the long-term remission monitoring is a standalone service. that somebody may move to after outpatient therapy stops, but there really can be obviously a whole lot of blending of long-term remission monitoring and outpatient therapy, which is active treatment of active disease that hasn't moved into remission yet. So some of the things that you do can overlap between 1.0 and 1.5, but just for the sake of having a nice diagram, this is the simplified version of the treatment continuum, the various levels of care, 1, 2, 3, 4, plus RR, as described in the current edition. This is it, 4th edition. Okay, now just as an example, we have a description of what level 3.1 care is. It's low intensity, clinically managed, motivational enhancement, relapse prevention. There is a 24-hour structure with trained staff and some clinical services if it is level 3 specialty addiction treatment, low intensity residential. You can call us a halfway house if you would like. It is professional care, and potentially a third-party payer would pay for it. So that's low intensity, clinically managed. Higher intensity, clinically managed is for people that need 24-hour structure. And this is most of what residential treatment is. It doesn't have as strong of a medical component as 3.7. So case management, educational groups, individual group and family counseling, motivational enhancement, all this stuff. And there's 24-hour support. Again, it's a residential environment, clinically managed, not medically managed. This is what most residential programs are. Same slide, maybe even simpler. Okay, so you're getting a sense of this. And again, we want you to try to get these concepts in your own heads. You don't have to refer to anything. 0.1 is lower intensity, 0.5 is high intensity, 0.7 is with a significant medical component, whether it's outpatient, intensive outpatient, IOP, residential. So that's the general framework of the new edition. So the 3rd edition had these levels, the 4th edition has these levels. And it's fairly comparable, but again, 0.5 goes away, 1.0 comes in, withdrawal management is integrated into the basic services. Very good comparability between the 3rd edition and the 4th edition with regard to IOP and PHP. There's now a new for 2.7. And again, that you could say that, certainly they do say that withdrawal management level 2 that involves medications is going to be a 2.7 process. Have the payers lined up according to the new criteria? I have no idea what they're doing about claims and medical necessity if they're using their proprietary criteria. We obviously, back in 91, wanted everybody to stop using proprietary criteria and use a national consensus and just one set. And that may never change, but we keep trying to make the criteria have better validity and reliability so that companies don't feel like they have to differentiate their processes based on their own proprietary criteria. So, so another just sort of a pictorial way to tell you what's different in the 4th edition. Okay, so we've had elements incorporated into new levels. We've had and revised and updated is the heavy bars. So I don't know what these little things are doing for us. These are obviously from the ASAM slide set. There's maybe some descriptors. Again, a descriptor of there's a tabular way of comparing. They used to call them crosswalks. I think there's still a big crosswalk in this edition, but this is a good side-by-side comparison of low intensity versus high intensity clinically managed residential treatment. And what are the services and what are the, how many hours a week of clinical care, et cetera. So there you go. And so it's 3.5, not 3.7. So you could say it's medically monitored in that physicians or advanced practice practitioners might review and sign off on the decision to admit to a particular level of care. So here's sort of a bigger overview of the 0.7s and how management of co-occurring general medical problems or general psychiatric problems can occur concurrently with the addiction service and withdrawal management at these different levels of care. So again, this is maybe a good cheat sheet to study from. And after this, you can look at just some of these sort of overview tables and things so that you can internalize this a little bit better for yourself. But, you know, I think 1, 2, 3, 4 are pretty easy to understand the differences. And 0.7 being medically managed is different than not medically managed. So this is where your you know, after the decimal point comes from, this is where the number before the decimal point comes from. And so this is, I think this is a nice general table using the new terms. So the authors are very, very clear. They said that evidence-based addiction treatment should include the ability to provide medications to anybody. And there should be a mechanism through collaborative practice agreements for any level of care to be able to have the medications. And if you have it in-house, then you're a medically managed program. If you have to refer out, then you're not a medically managed program. So all the FDA-approved medications, there's obviously no comment on non-FDA-approved off-label medications, but again, people with prescribing authority have the license, the freedom to do off-label prescribing. But they've put the physical exam in as an expectation. There should be a physical exam associated with an episode of addiction care. And if you don't have the ability to provide them in-house with your own salaried or contracted per diem professionals, you need to make sure it happens and you put it into the chart. And so when I was working in Madison, Wisconsin for a general hospital that had pretty much all 4 levels of care, this is one thing that I really tried to incorporate over 25 years ago, is that let's get a released primary care and get this person a physical exam. And we actually set up a system because we had all 4 levels and we had physicians under salary that, you know, we would do outpatient physicals. You just tell them. This is a recorder. Okay. We'll see. I'll have to deal with that after this, but it didn't allow me to customize the callback. They said, we're going to call back in. So I knew it was going to interrupt us a little bit. My apologies. So we're at the 40 minutes into it, Mark. I think we're doing really well. But everybody should have an assessment of whether addiction medications would be appropriate. And you can provide that by referring them to somebody else. ASAM being the American Society of Addiction Medicine, obviously it has over 1,000 non-physician members now. It's not just a physician organization, but it does take a medical approach because it's a medical specialty society, and it believes that that evidence-based treatment includes consideration of pharmacotherapy. And to not even consider it as an option is substandard care. So everybody gets some sort of assessment of would a medication be helpful for them. And again, the areas where the FDA has approved medications are tobacco use disorder, which is the biggest killer. More people with alcohol addiction die from tobacco than die from alcohol. There's meds for tobacco use disorder, there's meds for alcohol use disorder, and there's meds for opioid use disorder. So medication management is not just MOUD. In the term MAT, ASAM really wants to get rid of its medications for addiction treatment or medications in addiction treatment. you don't say medication-assisted treatment, because the treatment of pneumonia is not medication-assisted. It's just medications in the treatment of pneumonia. But the term that the feds have adopted, and I think most people in ASAM and throughout the field have adopted, is medications for opioid use disorder, medications for alcohol use disorder. So, at the VA where I work now, we use the terms MAUD all the time and MTUD. To not give the person a shot at, are you a candidate for medications, is considered not meeting the standard of care for specialty services now, according to the ASAM criteria. Your assessment of the patient should look at their medication needs. All levels of care should be able to initiate meds. Everybody should have a physical, and all clinically managed levels of care should be able to support the continuation of FDA-approved meds. If the person is in methadone treatment, they need to be able to either get take-homes, which are much more liberal now with the new regs, or be able to go to the clinic, and shouldn't be blocking their ability to do that. And you certainly should not be a level of care that actively sabotages pharmacotherapy. You should not be telling people, don't take these meds, don't take naltrexone, don't take buprenorphine, don't take acamprosate. We would hope that by 2024 we're past that. We know in reality we're not, but that's not considered acceptable professional practice for the treatment of this condition, which involves 100,000 overdose deaths a year now in this country. That's 1 million every 10 years. It's just unacceptable. So we need to improve the percentage of people get on meds, and addiction services at all levels should be supportive of meds, not ignorant of or hostile to meds. So, co-occurring disorders, the 4th edition promotes integration at all levels of care. Separate advanced standards are included for co-occurring enhanced levels of care. But everybody should be co-occurring capable. Now, what is this level 1.0? Boy, is this in opposition to the way managed care got into our business in the 1980s and 90s, where managed care said, you get a few sessions approved, and in their idea, fewer addiction sessions is better. We want to manage utilization to reduce the amount of care episodes. That is like completely misguided. It's wrong for public health. It's wrong for individuals. It's wrong for families. The more units of addiction care, the better, because not only does the patient function better, but they have less medical comorbidities requiring utilization of medical services. So in a carve-out world without parity, where you had all addiction care paid for by a separate benefit with separate limits, limit was what the name of the game was, but that doesn't get people well. Certainly, those of you who've had children know that there are what are called well baby visits. In pediatrics, you see the child periodically just because periodically you see the child to assess how they are, to detect things, to identify and refer, to implement more intensive services. In cancer care, obviously, people go back to see their oncologist. People go back to see the dermatologist after skin cancer. They're not sick. The status of their remission is monitored. That's what medical care is for chronic diseases. And this is a chronic disease. So you don't withdraw the treatment condition too soon. You keep some level of professional service there for 2 years or 5 years. And this is the way to do it. And so it's ongoing monitoring for patients in stable remission. Now, this really began in the addiction world in the what were called at the time impaired physician programs, the physician health programs. And there's professional monitoring programs now for, other disciplines, for nursing and psychology and counseling and social work and such. So the monitoring programs follow people for a required 2 years, and for physicians, it's 5 years is now the standard. And you want them to be in remission the whole time, but you want to monitor them to make sure that they are. You can do that by periodic drug testing. You can do it by, saliva testing. You can do it by ankle bracelets. You can do it by all sorts of means. There's a lot of people that monitor people over time. And this level of criteria really gets at that reality and says everybody should consider chronic disease management for this chronic disease. It may mean they stay on meds for more than 6 months. Certainly they stay on meds for longer than they're actively engaged with whatever's called active treatment at level 2.1, 2.5, 3.1, 3.5. You don't just have the person on naltrexone while they're in a residential program and then don't have it available to them later. These medications work if they stay in place. So, if you tried to assess the quality of medical services by doing it the way they do in our field, you'd be run out of town. Let's put you on insulin for a high blood sugar and for a high hemoglobin A1C. And then, after 90 days, we'll just take the medicine away, and then we'll measure how you're doing at 6 months and a year. That's the way addiction treatment is evaluated. How are you doing after the treatment condition has been removed? It's really unconscionable. It's unethical. You keep a treatment condition in place for a chronic disease. Now that the treatment condition may be a visit once a quarter, but it's professional care and it should be reimbursed. It's legitimate, ongoing care. So that's level 1.0. Remission monitoring, recovery management services can be delivered by a variety of providers depending on the patient's needs and where they're most comfortable. Regular monitoring enables providers to identify early signs that they may be resuming or at risk of resuming substance use. It's the way you look for triggers. It's the way that you talk to the patient and you see they're doing things that in other decades were called dry drunk behavior. They're doing everything but using, and their chance for relapse is really high because of what's going on. Now, we know this is just so obvious. If somebody's going through an episode of major depression or has experienced a major trauma and they have PTSD, their risk of relapse is much higher because they have this co-occurring active psychiatric problem. If you're doing regular monitoring and seeing a person every 60 days or 90 days or what have you, you have the chance to determine if there's something amiss that's like, whoa, do you need to get back and see your counselor regularly? Do you need to start meeting with your sponsor regularly? Do you need to get back to a 3 12-step meetings a week schedule? Do you need to get put on a medication? What do we need to do to respond to this increased risk of relapse before you've relapsed? That's what relapse prevention is. And so it gives you a chance to, metaphorically take the pulse of the patient, or literally take the pulse of the patient. How are you doing? We haven't seen you for 9 months. How are you doing? And if you're doing swimmingly, great. And you give them a handshake, a pat on the back, or possibly even a hug. But you don't ignore them after the first 90 days. That's not the way you deal with chronic diseases. So I'm obviously delighted that chronic disease management has been included in this concept. So, so these are the levels of level 1. 1.5 emphasizes psychotherapy and counseling and case management. Level 0.7 is medical services, management of HIV, management of Hep C, management of depression, management of, PTSD nightmares with medications. It's pharmacotherapy. Office-based addiction treatment with buprenorphine and maybe with methadone is coming if they change the federal law. That would be a 1.7 if it's low intensity, and 2.7 if there's a lot more contact and a lot more therapy integrated. So 1.7 is appropriate for people in early remission, but don't want to do the counseling. So some people, I found that in the patient population since I came out of retirement to do my current job, which gives me an opportunity to teach every day. That's why I do it. I work with trainees every day. But, there are patients who say, I want a medication, I want to do the counseling. For some patients, that's appropriate. For some patients, it's not. And you counsel them and advise them and develop a plan according to what you think are their needs. 3.7 is with the nursing care and with the ability to do things like, IV meds or wound care or Active withdrawal management, that's 0.7. Active medical management is compared to level 3.5, where non-physicians are doing the management. And 3.1 is just lower intensity. So, so there we go. 2.7 is integrating medical care with intensive outpatient clinical services, psychotherapy, counseling. Level 4 is unchanged, but it's quite rare. Be a specialty hospital unit for physiatry or a true inpatient dual diagnosis, where they have to meet the hospitalization criteria for their primary disorder, be that a spinal cord injury, a TBI, or a psychiatric problem. So if you really have addiction services fully integrated with these other services, that's level 4, and it's very rare these days. But it'd be nice if we saw more of it, if we saw more level 4 tobacco use disorder care, more level 4 counseling for people that are in the hospital for a heart valve replacement. That's the future. And there'll be some cutting edge, maybe academic medical centers that start doing that, is offering more addiction care integrated with their interventional cardiology care. ASAM recognizes that many standalone withdrawal management programs exist. Dane County, Wisconsin, where I practiced for 34 years, has had a freestanding residential detox run by a nonprofit contracting with the county. Hospital-based detox is not used anywhere near as often in Dane County because they have a really well-functioning standalone level 3 withdrawal management facility. So the goal of the changes in the 4th edition is not to eliminate standalone withdrawal management, but to encourage formal affiliations so that services are available to a broader range of people. You can look at page 21 to see what the authors were trying to say there. Cognitive impairments can be due to effects of substance use, effects of acute abstinence or subacute abstinence, post-acute abstinence, or can be due to additional medical conditions interfere with cognition. There was a description. The original sublevels of 3 were actually written by yours truly on my old Apple IIe computer in the study in my home in Madison, Wisconsin. I actually described the sublevels the first time around. We had halfway houses. We had programs that, keep people for 3 or 4 months when they have cognitive impairments. Some of the seniors programs for people with sort of naturally developing cognitive impairments, not just from an acute injury. But, take it at a slower pace. Those programs existed in Wisconsin. I knew about them. Other places offered programs that took into account cognitive impairments. And so we described them back then as level 3.5, but now the new authors say there's not as many freestanding programs. You don't, for somebody across county or state lines to get to one of these specialty programs. Let's just have some capabilities across the care continuum. And I can see the point, but this is a change that was made. The level of care for longer-term residential treatment, medically monitored, for seniors or people with other cognitive impairments, it's no longer described in this edition. It should arrange for physicals if you're not doing it self. And it says in all levels of care, physical exam should be done or arranged for. And that could be a copy from the primary care office where they were recently seen. And that's what we did at my agency, was we would send people out to their primary care. The counselors and IOP would say, get over to your primary care's office. And then we would have our docs do it for somebody that wasn't assigned to a primary care doc. Now there's more things that are available. We're doing pre-exposure prophylaxis for HIV now. And you can offer vaccinations. So looking at the patient's biopsychosocial needs broadly and responding to their medical needs is going to be described by a book that ASAM writes, you would think, and it is. So recovery support services, big stuff. putting people in various intensities of recovery residence to support their recovery. We know how important this is for so many people, and the concept in the fee-for-service, or I'm sorry, the commercial world of partial plus, they're getting PHP clinical services, plus they have a residence to live in, and that equates to, you know, residential care. But I mean, at the VA, I've been very impressed. I mean, we own and operate sober living houses that we can put people in while they're in IOP. I mean, the private sector should do that universally. So again, some of edition 4 is aspirational, like some of the things in the 3rd edition, or even 2R, were aspirational. So some of these things that are described, we want to see the field move in these directions. So again, NARR changed its nomenclature to the numerical system to align with what we're trying to accomplish. They used to be CS, M, and P, and now they're got some sub numbers on them. So I invite you to look at the book, the new book, to see how it describes the use of recovery residences. The term of risk rating is no there, but now we talk about dimensional drivers. So of these things you assessed in dimensions 1, 2, 3, 4, 5, and 6, and whatever, what were the ones that really made a difference in deciding where you're going to place the patient? Well, that phone's been busy today. Sorry. So what are the dimensional drivers? Sorry, I didn't mean to pick up. I'll have to call you back. I tried to slide my finger across and it pressed too hard. So get into the book to read this stuff on dimensional drivers. And so if you use the computerized version, it may be more obvious. If you're just doing your own thing, you can decide what are the dimensional drivers, what are the assessment dimensions or subdimensions that really were differentiating in your thinking as a clinician as to why a person needs a particular level of care. So that's a nice concept. Harm reduction is not a new concept. And, you know, I've been teaching on harm reduction for decades. And the idea that it's as opposed to abstinence-based treatment is unfortunate and misguided. Harm reduction is important everywhere. But one of the things about harm reduction is it says specifically, we can help the patient have a healthier life, even if they are not endorsing or succeeding at abstinence. And of course, in this day and age, fentanyl contaminating benzo illicit supplies, stimulant supplies, as well as opioid supplies on the street. The most important harm reduction is never use alone. Always be with somebody who can call 911 and hopefully can administer Narcan if you need it. So there's all sorts of harm reduction techniques. Obviously, don't use dirty needles, use a syringe or needle exchange. That's harm reduction. I don't believe that methadone treatment is harm reduction, like some people say. I don't believe that pharmacotherapy in general is harm reduction. I think that's misconceived. But there are things you do to reduce harm when people are still using drugs that are useful to integrate into any addiction treatment. It's an integral part of person-centered individualized care. But it also incorporates some of the concepts of low threshold addiction medication access. Get them on an opioid receptor blocker, even if they're using other things, because you can save their life. We had some special chapters in edition 3. If you've got an edition 3, don't throw it away. The section on tobacco use disorders is something everybody should read. It was aspirational, description of what different levels of care for tobacco use is, what it might look like. The gambling chapter, the safety-sensitive occupation chapter, the senior citizens chapter of edition 3 are still excellent. The new book addresses some new concept in integrating recovery support services, addressing cognitive impairment, assessing pain. There's a lot of chapters in the book besides just the dimensional criteria. So there's a lot in the book. And there's stuff not in the book, and we'll talk about what's next right now, and then we're going to wrap it up. What's on the market now is volume 1, adults. There's going to be a volume 2. I think volume 2 is going to be correctional more than child adolescent. There's going to be an adolescent volume, there's going to be a correctional setting, and then there's treatment of non-substance addiction. So there's for edition 4, there's going to be different volumes, and those are being developed as we speak, but they're not on the market yet. There's all sorts of implementation tools. I mentioned this, that ASAM has so many different tools that can be useful for you. It has training courses, it has a treatment planning template, and it's got a version that can be incorporated into an electronic health record. So this was out for, actually 2R is when Continuum first came out. It was revised for the 3rd edition. It's being revised now for the 4th edition. It's not out. It's integrated into an EHR, as is co-triage. So these are products that are available, and that's the link of how to understand more about them. I think BestNotes might want to think about this integration potential. So continues.
Sorry to interrupt, Dr. Miller. We do have the integration. It's live and available.
There you go. You gotta tout the benefits of BestNotes whenever you can. That's good. So these are some of the tools for assessment. This is what a computer screen looks like when you're going through the process. Withdrawal rating scales are built in. So BestNotes offers this capability. And there's better retention, less people dropping out of care, because if you don't see them, you can't help them. Patient retention is the #1 issue in addiction care, because like I said, if you don't see them, you can't help them. So so these are some ASAM slides on the value of Continuum and the co-triage 21-item structured interview that can help you with a provisional level of care placement. So I'm going to just wrap up here. We're at the top of the hour. You may find this particular tool of use and get one for your agency, and if you like it, maybe more. So a lot of these things are copyrighted. And then the guide on implementation is made by the Change Companies, who is the publisher of the 3rd edition. And then programs can get certified using a process that ASAM has partnered with CARF to allow programs to get a certification saying, we don't just say we offer these levels of care, we do. Services we offer do have fidelity to the ASAM criteria as written. And so you can, if you're an agency, you can attain level of care certification as a level 2, level 3, or both program. So there you go. And again, look at that little stuff below the seal on the cover, volume 1. So many of you are interested in the adolescent volume. Some of you are going to be interested in the correctional healthcare volume, and some of you will obviously be interested in behavioral addictions volume. Expect those from ASAM in the coming years. So again, don't have your arbitrary reasons for saying somebody can come in or can't come in. Do a biopsychosocial broad assessment, individualize the plan based on what you learn through that multi-dimensional assessment, and expect co-occurring conditions. There are people without them, but the majority have them. So not having them is the exception. Another slide just with some cartoons of things we've already said. And what was my lanyard? Oh, if you want to, these are some of the slides on research that's been done showing the evidence that supports the ASAM criteria. It's not smoke and mirrors. It really is an improvement in how to manage this severe chronic disease. So I haven't looked at the chat. I can stick around for a little bit more. And well, John, take it away. I haven't been monitoring the chat at all.
There's some wonderful questions in the chat. I know we are over time. Offline, Dr. Miller, I'm going to try to convince you to come back soon, and maybe we can have a Q&A session to address some of the great questions that came up today. And
Yeah, and an open-ended kind of thing, that'd be great. Not structured, just all Q&A. Sounds great.
that's
Happy
awesome.
to do it. We'll get that scheduled for everybody.
Excellent, excellent. Well, thanks for your time, everyone. Again, we will be posting this to our YouTube channel, so stay tuned for that, and we'll be in touch with more information via email.
Yeah, and we'll post all the slides that have some of those evidence things in it as well.
Excellent. Thank you for that, Dr. Miller.
Okay. All right. Thanks, everyone. The recording has stopped, says